Okay, good day everyone. Today we are on our 19th session of Learning Basic Arthroscopy series of lectures. Today we have a very important topic, that is anatomy of the shoulder joint. So we are going to cover the gross anatomy, the radiographic anatomy. Good day everyone. Today we are on our 19th session. Yeah, and also the arthroscopic anatomy. So we have Dr. Shreyas Dalaria. Let me share the screen. Okay. Dr. Shreyas Dalaria is orthopedic surgeon from Ahmedabad, Gujarat. He will be talking about the osseous anatomy and the radiological anatomy. Dr. Priyadarshi Amit will cover more in detail about the gross anatomy and also the arthroscopic anatomy. We have a special guest with us, Dr. Professor Radhakant Pandey. He is consultant orthopedic surgeon from NHS Leicester, UK. He is shoulder and elbow surgeon. And we also have Dr. Sriram Haris Srinivasan. He is orthopedic surgeon from James Paget University Hospitals, UK. So welcome everyone. Thank you very much for joining us today. Over to Dr. Shreyas.
Thank you, sir.
You can share your screen now.
Yes, sir. I'm fine. Okay, sir. Am I visible?
Yeah, you are visible. You can start the slide share.
Okay. Okay. Good morning, good afternoon, and good evening, everyone. Myself, Shreyas. First, I would like to thank Saseendar for this wonderful opportunity. I'm going to give an overview about the.
Dr. Shreyas,
Yes, sir.
please
Yes.
go to the full screen mode
Okay.
in your PowerPoint.
Yes, sir. Yes.
Slideshow.
Yes.
Yeah.
Yes. Yes, sir. Okay, sir. I'm going to give an overview about the radiographic as well as the gross anatomy of the shoulder. Let's start with the gross anatomy of the shoulders. The shoulder joint is composed of four articulations, which are sternoclavicular joint, acromioclavicular joint, glenohumeral joint, and scapulothoracic joints. Let's start with the glenohumeral joints. First of all, glenoid diameter. As we all know that glenoid is pear-shaped. That's why the epidiameter of the inferior of the glenoid is larger compared to that of the superior diameter. Superior AP diameter is around 18 to 30 mm, while the inferior AP is 21 to 35 mm, and the height of the glenoid diameter is around 30 to 48 mm. Going to the inclination, both the glenoid, as we all know, both the glenoid and humeral head is inclined upward, and the inclination of the glenoid is around 0 to 10 degrees. To measure the inclination of the glenoid, a horizontal line is drawn from the base of the spinous process of the scapula to the center of the glenoid cavity, which is depicted in the figure as a green dashed line. And one vertical line is drawn from the superior lip of the glenoid to the inferior lip of the glenoid, which is depicted in the figure as a uh, black line, and from where a perpendicular line is drawn, which is depicted in the figure as a red arrow. The angle between these two lines is inclination of the glenoid, which varies from 0 to 10 degrees. And the humeral head shaft angle is around 120 to 140 degrees, for which this is measured by two lines. One line corresponds to that of the anatomical axis of the humerus, and another line is the axis of the humeral head, and the angle in between these two is the humeral head shaft angle, which varies from 120 to 145 degrees. Coming to the version, both the glenoid and humerus is retroverted. The humeral head retroversion is around 0 to 55 degrees, and generally retroversion is measured with the help of the CT scan. To measure the retroversion of the humerus, two reference lines are drawn. One is the distal reference line and another is the proximal reference line. This is the distal reference line, which is basically an interepicondylar line which connects the lateral epicondyle to the medial epicondyle, and another line is the humeral head axis. This line is drawn from the tip of the greater tuberosity to the center of the humeral head, and the line and the angle between these two lines is the humeral head version, which varies from 0 to 55 degrees. And the glenoid retroversion is around 1.5 degrees. To measure this retroversion, two lines are drawn. One is the axis of the scapula. This line connects the medial scapular angle to the center of the glenoid, and a perpendicular line is drawn to this line, and another line is drawn from the anterior lip of the glenoid to the posterior lip of the glenoid. And the angle between these two lines amounts the retroversion of the glenoid, which varies around 1.5 degrees. The surface area of the glenoid is around 4 to 6 mm, and the surface area of the humeral head doubles to that of the glenoid, is around 11 to 19 mm. Cartilage thickness of the glenoid is 2.16 mm, and cartilage thickness of the humeral head is around 1.44 mm. Humeral offset. Humeral offset is basically a displacement of center of rotation of the humeral head from the humeral anatomical axis in both the transverse as well as the coronal planes. That means that the humeral head doesn't lie in the same plane as that of the anatomical axis of the humerus. It is in the coronal plane. The cora is they are medially displaced around 4 to 14 mm, and in the transverse plane it is displaced minus 2 to 10 mm. So what is the importance of this humeral offset? To do the during the replacement, if the offset of the prosthetic head is too much, then overstuffing of the joint occurs, which leads to increased wear and tear and decreased range of motion. And if the offset is too less, then the glenoid and the supraspinatus loses its lever mechanism, and there is an impairment in the abduction and decreased range of motion. Normal function of the shoulder is a balance between mobility and stability. To provide vast range of motion, stability of shoulder joint is compromised. Mainly the stability of shoulder joint is provided by the soft tissue surrounding the shoulder joint, very less by the bony anatomy. These are the soft tissue constraints. There are three. One is labrum, ligaments, and muscles. As I have already told, the surface area of the glenoid is very much less compared to that of the humeral head. So glenoid cavity is basically deepened by the labrum surrounding the glenoid cavity. The depth of the socket is increased by 50% with the help of the labrum. Then there are ligamentous constraints. These are the primary stabilizers of the shoulder joints. There are three ligaments: the superior and middle glenohumeral ligament and the inferior glenohumeral ligament complex. What are their functions? The superior glenohumeral ligament is a primary restraint to anterior and inferior subluxation of the humerus in 0 degree of abduction, while the middle glenohumeral ligament is a primary restraint to anterior subluxation of the humerus at 45 degree of abduction. Then there is inferior glenohumeral ligament complex. Why it is called as complex? Because there are three structures there. There is an anterior band, then there is a posterior band, and then there is axillary pouch. The inferior glenohumeral ligament functions at the extreme of motions. It is a primary restraint to the anterior shoulder subluxation in the extreme of motions, and the anterior band of the inferior glenohumeral ligament functions during the external rotation, and the posterior glenohumeral and the posterior band of the inferior glenohumeral function acts during the internal rotation of the humerus. The muscular constraints, the muscles of the shoulder joint is divided into two groups: extrinsic groups and intrinsic groups. Extrinsic group contains rhomboids, levatoscapula, trapezius, serratus anterior, and intrinsic group contains rotator cuff, deltoid, and biceps. Now let's talk a bit in detail about rotator cuff. It is composed of four muscles: supraspinatus, subscapularis, infraspinatus, and teres minor. All these four muscles inserts to the greater tuberosity of the humerus, which is called as footprint. Subscapularis causes internal rotation of the humerus, while supraspinatus causes the abduction of the humerus, and infraspinatus causes the subluxation of the humerus.
Shreyas. Shreyas, can you hear us?
Yes, I'm here. Okay. Am I visible, sir?
You are visible, but you need to share your screen.
Okay, sir.
Yeah, you can go ahead.
Okay, sir. So coming to the rotator interval. So why it is called as interval? Because there is no rotator cuff tendon present at this triangular space. It is located anteriorly and superiorly to the shoulder joint. It is bounded by four structures: superiorly by the supraspinatus, inferiorly by the subscapularis, medially by the coracoid process, and laterally by the transverse humeral ligament, which also corresponds to the apex of the rotator interval. It contains three structures: the coracohumeral ligament, the biceps tendon, and the superior glenohumeral ligament. Clinical importance: it is generally contracted during the in the adhesive capsulitis, and it is expanded in the shoulder instability. The coracoacromial arch, it lies superior to the glenohumeral joint, and it is formed by the four structures: the acromion process, the coracoacromial ligament, the coracoid process, and the distal clavicle. Generally, the rotator cuff tendons, especially the supraspinatus, the subscapularis bursa, and the biceps tendon, all passes beneath this arch. The space is required to do the normal functions of the shoulder joints. If narrowing of the space occurs, that leads to mechanical impingement of the shoulder joint. The coracoacromial arch also serves as a restraint to to proximal humeral migration. Its disruption is considered the final step in advanced degenerative shoulder disorders associated with massive rotator cuff tears. That was all about the gross anatomy of the shoulder joints. Now let's talk about the radiography of the shoulder joints. Radiographic technique, shoulder radiograph series may be needed for a particular conditions such as arthritis, trauma, instability, or impingement. Depending on the clinical situations, additional views may be obtained, as shown in this table, that there are various clinical situations are there, and various views for the particular situations are there. I'm going to talk about some of the views in subsequent slides. Let's go to the first view, anterior-posterior view. It is a key component of basic shoulder series. Often the epi projections are obtained either with the arm in external rotation or in internal rotation. Following 4 points are assessed. These are, as I have told, that both the glenoid and humerus are retroverted. In the AP view, there is an overlap between the glenoid and humerus. If this overlap decreases or disappears, it mainly occurs due to the posterior dislocation of the humerus. Then there is a acromiohumeral distance. Normally, this distance is around 7 to 14 mm. But if this distance is less than 7 mm, then one can suspect proximal humeral migration. Also, Maloney's arch corresponds to that Shenton's line of hip. Maloney's arch, some of the study says that Maloney's arch also a sensitive indicator, even more sensitive to the acromio humeral distance to visualize the proximal migration of the humerus. And the greater tuberosity profile is best seen in this view. And with the epi view in the internal rotation, the Hill-Sachs lesion can be seen very easily at the posterior superior aspect of the humeral head, which represents a compression fracture due to shoulder instability. Okay, what are the techniques to obtain the AP view? It can be obtained with either patient in supine position or in erect position. The patient and cassets both lies parallel, and the X-ray beam focuses on the coracoid process. Rockwood view. Rockwood view is basically a modification of the AP view. In this view, the position of the patient is similar to that of the AP view, but the X-ray beam lies, the X-ray beam angulates caudally at 30 degree. It is utilized in the impingement series. to check for the acromion and subacromial space. This is an X-ray of shoulder in the Rockwood view, in which we can see here a line from the inferior aspect of the clavicle to the inferior aspect of the acromion. If any bony prominence projects below, extends below this line, or any osteophyte presence below this line, then one can suspect impingement syndrome. So this view is basically for the subacromial space and to evaluate the acromion. Then next is Gracie view. Gracie view is basically a true anteroposterior view of the shoulder. As we have seen in the AP view that there is an overlap between the glenoid and humerus, but in Gracie view that overlap is removed either by angling the X-ray beam 45-degree laterally or by rotating the patient 45-degree towards the affected shoulder. And this is how we obtain the Gracie view. It is generally basically to determine the glenohumeral joint and the thickness of the cartilage thickness of the glenohumeral joint. So this view is basically for the arthritis, to check for the arthritis of the glenohumeral joint. Then fourth is the axillary view. This view is obtained with the patient lying supine on the table and the arm is abducted at 90 degree and the X-ray beam is focused on the glenohumeral joint and it is angled 30 degree to medially. This is an excellent method to visualize, to check for the glenohumeral subluxation and osseous Bankart lesion. In this X-ray, we can see that the humerus is anteriorly subluxated and there is an osseous Bankart lesion is also present. Then there is a West Point view. West Point view is a variation of the lateral axillary view. It was basically developed to improve the detection of the Bankart fracture of the anterior glenoid ring. How to obtain this view? The patient lies prone on the table with arm abducted 90 degree and the X-ray beam is focused on the glenohumeral joint. But in this view, the X-ray beam is angled 25 degree medially and 25 degree caudally to visualize the anterior glenoid rim, anterior inferior glenoid rim. Scapular Y view. Okay. Why it is called as Y view? Because in this view, the glenoid process seen as a Y-shaped. This is an glenoid process which is seen as a Y-shaped, and one arm is formed by the acromion process, one arm is formed by the coracoid process, and the base is formed by the scapular body. And the humerus head is centrally located over the glenoid fossa. This is an excellent view to check the anterior or posterior dislocation in the trauma setting when the patient is unable to move his arm. How to obtain this view? The scapular Y view can be taken in the erect or supine position in the P direction with the affected shoulder rotated anteriorly at 45 degree. The arm is positioned at the side, superimposed on the scapula. Then there is a supraspinatus outlet view. It is basically a Y view, but it is a modification of the Y view. The position of the patient is similar to that of the scapular Y view, but in this view, the X-ray beam is angled 10 degree caudally to visualize the subacromial abnormalities and acromion process. As we can see over here, the outlet can be visualized very clearly. It is the outlet of the supraspinatus and acromion process can be visualized very clearly. Then eighth is striker notch view. This view nicely demonstrates the posterolateral aspect of the humeral head and is excellent for depicting a Hill-Sachs deformity or flattening of the posterolateral humeral head. This is how this view is obtained. Patient lies supine on the table with the head is supported by the back of hand and the elbow is facing towards the ceiling and the X-ray beam is focusing over the glenohumeral joint, but the beam is angulated 10 degree cranially. And in this X-ray, we can see that the Hill-Sachs lesion, Hill-Sachs deformity can be visualized very clearly. So West striker notch view is basically was developed to detect the Hill-Sachs deformity very clearly. To summarize all the views and their utility, anteroposterior view is basically for the overall impressions of the glenohumeral joint, acromioclavicular joint, and distal clavicle. Gracie view is again for the osteoarthritis of the glenohumeral joint to check for the glenohumeral cartilage space. Axillary view was for the subluxation or osseous Bankart lesions. West point view is to check for the anterior inferior glenoid rim, especially for bony Bankart lesions. Rockwood and supraspinatus outlet view is for subacromial space, and striker notch view is for posterior superior humeral head, and especially for Hill-Sachs deformity. Thank you, sir.
Thank you very much, Dr. Shreya. That was a very clear and crisp presentation on the osseous anatomy and the radiological anatomy of the shoulder joint. Thank you very much. You can unshare your screen.
Yes, sir, I'm doing it.
Yes. Okay. Welcome, Dr. Amit. You can go ahead with your presentation on the gross anatomy and also the arthroscopic anatomy of the shoulder. The shoulder is a very complex joint to understand, so I am very positive that.
Any questions now, Sasi, or you're taking questions later on?
No, sir. We are going to have the questions finally at the end,
okay,
after both the presentation. Thank you. So, go on, Amit. Dr. Amit, you have to unmute.
Yeah, you can hear me, I believe.
Yeah, you're clear, and you can go ahead with the sharing. Yeah.
Okay. So, hello everyone. It's Mr. Priyadash from Birmingham, UK, and yeah, many thanks to Dr. Saseendar, one of my very good friends, for providing me this opportunity to speak on this podium. It's always an honor to be here and share my knowledge. So, and congratulations to Dr. Shreyas, who has given a very good overview of anatomy of the shoulder joint. I'll try to take it slightly deeper into complex anatomy of the shoulder joint. So I have divided that in 6 chapters. One is intra-articular, then subacromial space, and then anterior subdeltoid space. Then we'll be talking about muscles in the shoulder, and then coracoid and its attachment in detail, and then at last we'll be talking about some nerves. Let's go to intra-articular anatomy. As we have seen, it's a ball and socket joint. It's formed between glenoid and humeral head, but this articulation is inherently unstable, which is very well very good analogy similar to what a golf and tee model is. So a large ball rests on a very small surface area of glenoid. Now this, as we have heard earlier, that it's a soft tissue constraint which stabilizes the shoulder joint. However, we cannot underestimate the effect of negative intra-articular pressure, which gives a cavity compression effect in the shoulder joint. This is a cadaveric video. Before I speak further, I would like to declare that in this presentation, I have used many cadaveric images, arthroscopic videos, which are not mine. They have been obtained from online educational sources. So yeah, coming back to negative intra-articular pressure, this cadaveric video is of the right cadaver when the deltoid has been reflected. What we see here is that the humeral head overlying with overlying rotator cuff tendons, and that's a bicipital groove where the scissor is going to go. So as we see, as the bicipital groove is being opened up, take a note of the subacromial space, which opens up, which increases. So that denotes that as soon as the bicipital groove is opened up, the air gushes in, which obliterates the vacuum phenomena, and that is destabilizes the shoulder a bit. Next, we heard about labrum giving a very having a very stabilizing factor in the shoulder joint, where it increases the surface area. But we would like to focus on one entity which was earlier thought as an anatomical variation of labrum. That's called the Buford complex. Now, in this complex, the labrum is absent in anterior aspect in 1 to 3 o'clock position, with the middle glenohumeral ligament very thick, and then which starts from the superior labrum. Now, though earlier thought was that it's a benign lesion, however, there are a few reports coming up that it's been associated with lesions of superior glenohumeral ligament and also anterior superior labrum. Now, we have heard about long head of biceps tendon, which originates from the supraglenoid tubercle inside the shoulder joint and then traverses through the bicipital groove. Now, the bicipital groove has an important feature where it's been found that from the top of the bicipital groove to the bottom of it, it internally rotates by about 9 degrees. And there are a few papers which suggest it's around 15 degrees. Now, this variation, if its location, it's very important in those situations if one is doing a shoulder arthroplasty procedure for 4-part fracture, where they have to base the anatomical head component on the basis of bicipital groove. Now, we heard about different glenohumeral ligament to provide stability, namely superior, middle, and inferior glenohumeral ligament. In this cadaveric image, we see the distinct attachment of those anatomical structures. So this is the right shoulder cadaveric image where the deltoid and the posterior superior cuff has been reflected, and now the scalpel is used to reflect the subscapularis. And here we see the biceps tendon in the top end. Underneath that, that is anterior to that, we find superior glenohumeral ligament starting from the anterior glenoid and inserting onto the lesser tuberosity. And actually it forms, with the help of subscapularis, it forms the pulley, which is the medial pulley of the biceps tendon, and also it forms the floor of the bicipital groove. And then lower down, we find MGHL, which is middle glenohumeral ligament, again originating from the anterior glenoid and inserting into the subscapularis and the capsule. With further procedure, when the subscapularis has been reflected completely off, you can appreciate the middle glenohumeral is not in fact attaching to the subscap, but it is attaching to the capsule, and that's where its insertion is. Going further, subscapularis has been completely taken off along with the capsule and MGHL, and then that shows the location of inferior glenohumeral ligament, and it's actually the anterior band of inferior glenohumeral ligament. Now this picture, this is the left shoulder anterior image, which describes the 3 common ligaments along with the biceps tendon and the 2 rotator cuff tendons. So you start with the supraspinatus on the top, inferior is the subscapularis, and there's a big ligament in between these 2 tendons, which originates from the coracoid process and inserts onto the lesser tuberosity. In fact, that is called coracohumeral ligament, and it has got insertion into both greater tuberosity and the lesser tuberosity, and it helps forming the lateral pulley and roof of the bicipital groove. Inferior, you can briefly see the MGHL. This view does not show superior glenohumeral ligament. However, from the lateral side, if you reflect the coracohumeral ligament, if you pull the coracohumeral ligament anteriorly, that exposes the superior glenohumeral ligament underneath the coracohumeral ligament, and you can see that that's forming the medial pulley of the long-headed biceps tendon. So having looked at all these structures, long-headed biceps tendon, superior glenohumeral ligament, and coracohumeral ligament, these all 3 structures form the basis of rotator interval, with the importance of which we have already heard. As you can see in this MRI image, that's a supraspinatus, subscapularis, and the area between those 2 ligaments are, these 2 tendons are structures composing rotator interval. Now let's go and look at the muscles around the shoulder. As we heard, it's an extrinsic muscle group and an intrinsic muscle group. The important feature in the intrinsic muscle group, most important thing which we talk a lot about these days, that's a footprint of the rotator cuff tendons. Now in the middle there is a supraspinatus, posteriorly infraspinatus, further down would be teres minor, anteriorly would be subscapularis, and that's a coracoid process. Now this posterior superior cuff tendon, which is supraspinatus, infraspinatus, and teres minor, insert onto the greater tuberosity. Historically, it's been thought that there are 3 facets in the greater tuberosity: medial or superior, then middle, and then inferior. The supraspinatus inserts onto the medial facet, infraspinatus onto the middle facet. However, recent work done by Sugaya et al. From Japan, they say, based on their investigation of cadavers, they say that, in fact, infraspinatus inserts onto the middle facet. Along with that, it inserts into majority of the medial facet. while in few individuals, supraspinatus is seen inserting onto the lesser tuberosity also. And on the medial facet, supraspinatus has got a smaller footprint area. This you can visualize better in this cadaveric image, which is again looking from the lateral side. That's a joint, and supraspinatus has been just reflected off. However, you can see the infraspinatus fibers coming and inserting up to the bicipital groove, this triangular region. This holds an importance in the way rotator cuff is repaired. For example, in this image, you can see the two layers of rotator cuff tear with a deep layer and superficial layer. As we saw in a previous image, a superficial layer is mostly supraspinatus and deep layer is infraspinatus. And the retraction of the deep layer is mostly posteriorly, while superficial layer retracts mostly medially. And while repairing, the anatomical position of the deep layer, which is infraspinatus, has to be maintained, that this portion of the deep layer of cuff tendon has to go in the medial part of the medial facet. Now, another important structure in the cuff tendon is rotator cable, which is a fibrous sheath that extends from the coracohumeral ligament attachment onto the lesser tuberosity, goes around the supraspinatus whole width, and then courses through the partial width of infraspinatus and then inserts here. Now, this has been named as a suspension bridge in the rotator cuff, where it acts to dissipate the force couple along the rotator cuff tendons. In this view, this is an intra-articular view where there is a humeral head and these are the cuff tendon. You can visualize or you can appreciate the rotator cable, which is starting from the very next to the bicipital groove and courses along the whole width of supraspinatus and then inserts along the infraspinatus here. That's called the rotator cable, and this is the structure lateral to the rotator cable is called rotator crescent, and it's been found that rotator crescent is slightly weaker in character and has got less vascularity, and that's prompts it to be location for initial tear in the rotator cuff. Further on, the studies have shown that in young age, rotator crescent is quite thick while the cable is thin, but as the age progresses, crescent becomes thinner and the cable becomes more and more thicker. That's why the cable crescent ratio increases with age. And that probably explains the amount of degenerative tear which we find in the crescent area. Now, based on the crescent tear, and sometimes the cable is involved in the tear, they have classified this into cable involving tear or crescent involving tear. And more commonly, the cable involving tear are more symptomatic and undergo more fatty degeneration and mostly surgical. And there is a high risk of re-tear in the cable-related tear. Okay, this is the arthroscopic image where you can appreciate the rotator cable, and that's a crescent area. And same way in the MRI, you can appreciate the hyperintense shadow here, which denotes the rotator cable. Practical implication of rotator cable, while repair, it's what the study have seen that the rotator cuff repair involving this portion of the cuff, that's a crescent area. If the bite is taken through that area, that's inherently weak and there is a high risk of re-tear. However, the best stitches are taken through this area of the rotator cuff, which is medial to the rotator cable. Small talk about subscapularis. That's an anterior group of muscle, an anterior rotator cuff muscle which inserts into the lesser tuberosity. And the inferior portion is denoted by the three sister, famously called as, which are actually anterior circumflex humeral artery and its vena comitatus. And that's subacromial space overlying rotator cuff tendon under the deltoid. Now we go on to the extrinsic muscle. I think two muscles need mentioning here in surgical anatomy of the shoulder, which is pectoris major and latissimus dorsi. Now, pec major is a broad-shaped muscle having three origin from the clavicular and then sternal and costal, famously called as clavicular head and sternocostal head. And they insert onto the lateral lip of intertubercular groove. Now it inserts with two lamina. The top lamina is formed by a clavicular head and the inferior lamina is formed by sternocostal head. Now, important thing to understand is that sternocostal head, while coursing, it goes superolaterally and the clavicular head courses infralaterally. This relationship is quite important when one is performing a pectoralis major repair. And here in this cadaveric image, you can appreciate the sternocostal head and the clavicular head. And what we know that the broad insertion of each lamina is around 5.4 centimeter. And if you combine both the insertion, it's around 6.8 centimeters. So it's a very lengthy attachment. Now, the relationship of pec major with other structure is very important. First, in case of pec major repair, and second, in case of arthroplasty procedure, which is performed in complex proximal humerus anatomy, when the pec major or insertion is taken as a landmark to assess the humeral length. Now, in relation to the latissimus dorsi, so this image, that's the latissimus dorsi, that's the intertubercle groove, and that's a pec major. Now, the distance between the tip of latissimus dorsi insertion and the pec major insertion is around 9 millimeter. And in the same way, in this image, that's the pec major insertion which has been detached, and that's the biceps tendon. Now, the distance from the superior part of the proximal humerus or greater tuberosity to the proximal end of the pec major insertion is around 56 millimeter. And in this view, compared to when you assess that from the anterior deltoid insertion, it's around 45 millimeter. Now, next measure is latissimus dorsi. Again, it's got a broad origin in various structures and inserts into the posterior lip of the intra-articular groove, as you can see in this picture. So that's again the right shoulder cadaveric image where the deltoid muscle is reflected laterally. Pec major has been detached, and you can see the pec major insertion point, and the conjoint tendon is retracted medially, and that's along with the biceps tendon. And this whole area is the latissimus dorsi insertion point. Now, this anatomy is very important if in those cases where you are going to do a latissimus dorsi transfer to augment the external rotation, reverse shoulder arthroplasty. Now, looking at coracoid process, an important bone and has very important attachment. Now, if we see the attachments doing clockwise, the first structure is conjoint tendon, which is actually missing in this image. However, the second structure, pectoralis minor, which inserts onto the medial aspect of the coracoid process. Proximally towards the coracoid base, there are two coracoclavicular ligament, namely trapezoid and conoid ligament. Going further, there are coracoacromial ligaments, anterior and posterior part of those. And then inferiorly, if you see this ligament, coracohumeral ligament, we have seen in cadaveric images earlier. Now, the origin point is from the lateral aspect of the coracoid process along its inferior surface. Now, if you look at the cadaveric image, it's also called as a center of the star. That's a coracoid process with four dimensions, 4 attachments in different directions. Inferiorly, that's a conjoint tendon. That's big muscle is pectoralis minor. That's coracoclavicular ligament, and that one is coracoacromial ligament. Here again, we look at the same structures. Again, right shoulder, coracoid process, that's a humeral head with various tendons. And when you see the conjoint tendon, now it inserts into the apex of coracoid process. However, it has also got some attachment to the coracoacromial ligament in the anterior portion of that. And then this coracoacromial ligament inserts onto the coracoid process. And it's earlier it was thought that it's got a broad single origin. However, now it's the two origins are distinctive, anteriorly and posteriorly. As you can also see in this image, the two coracoacromial ligament insert onto the inferior surface of anterior and partly onto the lateral aspect of the acromion. And then there are two coracoclavicular ligament, trapezoid and conoid. Conoid arising from medially into the from the base, and trapezoid slightly anterior to that. and they both insert into the inferior aspect of the clavicle, where conoid is slightly posteriorly and trapezoid is slightly anteriorly. When we look at the dimension of coracoid, that measures around 44 millimeter, and just the base, it's around 17 millimeter. Now, if you look at the distance between tip of the coracoid and the anterior portion of the posterior coracoacromial ligament, that is around 20 millimeter. And that's the most common amount of bone you need while performing a coracoid osteotomy. And if you compare the distance between coracoid apex and the trapezoid ligament, that measures around 24 millimeter. In male, it's 26 millimeter, and female, it's 22 millimeter. So it's been recommended that at no cost the coracoid osteotomy should go into the trapezoid ligament that may destabilize the coracoacromial ligaments and for the acromio-clavicular joint. So that's the maximum limit of the coracoid osteotomy. Now again, the same thing, coracoid process here, and you can see these two ligaments inserting into the inferior aspect of the clavicle, and that's the acromio-clavicular joint. To understand better, we look at the inferior aspect of inferior view of the clavicle bone. So that's an acromial end. Next would be acromio-clavicular joint. And if you say that's a trapezoid ligament attachment, which is slightly anteriorly, and that's a conoid ligament attachment slightly posterior onto the conoid tubercle. Now, if you measure the distance from the acromial end, that measures about 15 millimeter, and then the coracoclavicular ligaments start, and the whole width of coracoclavicular ligament is around 25 millimeter. So this has implication in two surgeries, like if you're doing AC joint resection surgery, so at no cost you should violate the trapezoid ligament, so you should limit your resection less than 15 millimeter. In my practice, it's around 5 to 10 millimeter. And then also while performing AC joint reconstruction, these two ligaments anatomy should be respected while performing that surgery. Having seen the gross images, let's look at the intra-articular video. So what all the structures are. So this video is taken in B-chair position with the scope in the posterior portal. Sorry. So the first structure encountered in the shoulder arthroscopy is the long head of biceps tendon as it inserts into the superior labrum. And then you look at the cartilage, both the glenoid and the humeral, where you can appreciate the bare spot on the glenoid. And then you retract the scope posterior and look at the posterior labrum, which is attached on the posterior glenoid. And then you go inferiorly and look at the inferior glenohumeral ligament, and that's the rhesus. And then you go posteriorly and look at the bare spot, which is the area of the humeral head devoid of cartilage. Now, I have paused the video just to mention one point that in the anatomy is when you look at the cartilage and how far it is from the rotator cuff attachments, the superior cartilage is just 1 millimeter away from the rotator cuff attachment, but however, inferiorly, it's around 13 to 15 millimeter. So that denotes the area of the bare area. And then you go proximally, superiorly, and look at the posterior rotator cuff. And then that's superior rotator cuff, that's supraspinatus. And then you look at the biceps tendon traversing through the bicipital groove. And then you appreciate two pulleys of the biceps tendon, one medial and one lateral. We already talked about what ligament forms this pulley, and they're important in assessing all those lesions of the biceps pulley to assess the stability of the biceps tendon. And then anteriorly, that's a subscapularis tendon, and that's a superior glenohumeral ligament in the rotator interval. And again, going further, that fibrous band, which is present in posterior to the subscapes MGHL. And then you assess the anterior labrum. I understand there are various ways of and various sequence of arthroscopy. Doing a diagnostic arthroscopy, which may vary from person to person. Now, having looked at the intra-articular diagnostic arthroscopy, let's look at the subacromial space. Now, these are my portals with the posterior portal having scope, and the lateral portal, I use my shaver. So with a shaver, minimal bursectomy is performed. That should be enough to visualize the rotator cuff tendon and other pathology. And it's mainly important to visualize the acromion and pathology of the CAL, which you can see in impingement syndromes, and then rotator cuff tear. So on the floor of this subacromial space lies rotator cuff, which is posterior superior cuff tendon, and on the roof you can appreciate that's the rotator cuff, and it's got a rent between supra and infraspinatus. And then you go superiorly, and there you assess the and there you look at the coracoacromial ligament and acromion. Now, this is an emerging space into the shoulder joint subdeltoid anatomy, which is located anterior to the subscapularis and posterior to the deltoid. It's been used for various surgeries, such as arthroscopic letter or brachial plexus exploration, and also for performing AC joint reconstruction or stabilization. A few people have started doing it for subscapularis repair. Now, this again, this is again the anterior view of right shoulder, where the deltoid and pec major had been detached, and you appreciate the subscapularis tendon, lesser tuberosity, and that shows interesting anatomy of the three sisters. Now, the subdeltoid space is divided into two parts. One part which is lateral to the conjoint tendon, and the other one medial to the conjoint tendon. And this is how I approach subdeltoid space. So again, V-chair position, and looking from the posterior portal, that's a humeral head, that's subscapularis. On the top, we have coracoid process, and attached is coracoacromial ligament, and this broad tendon is conjoint tendon. And I mark my portals as this is my anterior portal in this space, and further down is anterolateral portal. And I take care to, I do with needle outside in technique, so I take care that the needle goes straight parallel to the subscapularis, 1 centimeter above it. And again, we start with the arthroscopic videos, and these are my portals. So my viewing portal is posterior, and then anterolateral and anterior portal are my working portals. So we start the video. Anterior portal is being made, and thereafter the rotator interval is gradually taken down, taking care not to injure the important structures. So here the rotator interval is taken down from the subscapularis, and that opens the space anterior to the subscapularis. And then the coracoid process is felt, and then tissues overlying it are resected, and gradually the coracoid is denuded along its inferior aspect. And now the coracoacromial ligament is being detached, and you can appreciate the attachment of conjoint tendon to the coracoacromial ligament. And once it's detached completely, this lifts off the deltoid from the coracoid process. And here, all the tissues are being detached from the superior aspect of the coracoid process. Then after doing this, the conjoint tendon is delineated, so resecting tissues from both its lateral and medial attachment. Now the anterolateral portal is being made, and now actually the scope is changed to 70°, which gives a very good overview of the subdeltoid space anteriorly. And walking through the anterolateral portal, tissues are dissected from anterior to the subdeltoid, and if you keep proceeding medial to the conjoint tendon, you come across the brachial plexus. Now we talk about the brachial plexus. This can often be a nightmare for shoulder surgeons, as in many surgeries, such as your Latarjet procedure, whether be it's arthroscopic or open, or even shoulder arthroplasty in a very tight shoulder, you can come across the brachial plexus palsy with most commonly musculocutaneous and axillary nerve and radial nerve. Now, if you understand the anatomy of brachial plexus, it starts from the cervical plexus, courses under the middle part of the clavicle, courses down, then posterior to the pec minor, overlying subscapular muscle, and then along under the conjoint tendon. This you can appreciate better in this cadaveric image. So there's again the right shoulder, acromial process, humeral head, coracoid process, that's the conjoint tendon. These are CA ligament. On this side, you can appreciate the pec minor tendon, and that's a big rope-shaped structure is the brachial plexus, and that courses posterior to the pec minor muscle. Now, that's a relationship of different nerves and arteries in the brachial plexus. So we are looking at the left shoulder now with a deltoid contour around this aspect, and that's a coracoid process which has been osteotomized, and you can see the conjoint tendon lying here. And the first structure, as you go medial to the coracoid, you appreciate the musculocutaneous nerve, and behind that is axillary artery and axillary nerve. Now, again, in this picture, you see the anterior view of the shoulder, where you can appreciate the coracoid process and the conjoint tendon, and that structure is all brachial plexus. Here, with the retractor, the brachial plexus, the nerves are retracted medially when the axillary artery and its branches are exposed. Going further, here you can understand the anatomy of different structure of different parts of brachial plexus and artery in the inferior aspect of the shoulder joint. So we have viewed it on the top earlier around the coracoid process, but as it traverses inferior and laterally, the topmost branch is axillary nerve, and further inferior you appreciate the musculocutaneous nerve. And axillary nerve, you can appreciate it crossing under the inferior capsule of the shoulder. And if you keep tracking the axillary nerve, you look at the posterior aspect of the shoulder joint, and that's the inferior joint capsule, that's a deltoid. You have split the deltoid, and then you try to look deep inside the shoulder joint, under the inferior joint capsule, you see that axillary nerve is coming out. Now, this is important because there have been few reports. In fact, this year they have published a report from a study from Japan where they have got 0.2% of axillary nerve damage in various stabilization surgery. And they have measured the cadaveric distance between the inferior capsule and the nerves, where they have found that it's 3.4 millimeter on an average. And at times it can be as close as 1 millimeter. Then you have to really take care when you're taking a bite for capsulography during a stabilization surgery. And if you follow the course of axillary nerve, it winds around the neck of humerus, and you can appreciate that coming down anteriorly, where and as it's lifted along with the deltoid, it supplies the deltoid muscle. This has got relevance with respect to anterosuperior approach, when the distance between axillary nerve and the acromial process is around 5 to 6 centimeter, and this relationship has to be respected while doing a modified McKenzie approach. Otherwise, it may injure the branches of the axillary nerve to the anterior deltoid and following the palsy. Now, having looked at the gross anatomy, this video will show you to explore the axillary nerve arthroscopically. So this is again B-chair position, and it's of the right shoulder. And the viewing portal is actually lateral, and anterolateral is the working portal. And on the left, you appreciate the subscapular tendon overlying the humeral head. So we play the video. So on the right, you appreciate the conjoint tendon, and with radiofrequency device, you try to dissect all the tissues, and deep immediately you appreciate some fats. And then it's time to change it to a blunt trocar or a switching stick, and gently you dissect the tissues. And here you can appreciate axillary artery pulsating, and further exploration will reveal the axillary nerve, and that's the axillary nerve. Now, last in my talk is suprascapular nerve. This is one of my favorite. So suprascapular nerve is a branch originating from the upper trunk of the cervical plexus, and it traverses under the trapezius and then omohyoid, and when it passes through the suprascapular notch here, And the nerve is under the transverse scapular ligament, while the artery is on the superior aspect of the transverse scapular ligament. Then it courses, it supplies the supraspinatus here, but it courses down along the spinal glenoid notch, where it is again, both the structures are under the spinal glenoid ligament, and then it supplies the infraspinatus. Another important feature of this is relationship with the glenoid surface is that the distance between nerve and glenoid surface is around 2 centimeters, and that limits the area where a surgeon should work in order to fix the posterior glenoid. Now, same structure we're looking from the top. So we're looking at the suprascapular fossa. That's a clavicle. That's a acromiclavicular joint. That's the spine of scapula. And that's the coracoclavicular ligament overlying the coracoid process. And as you follow the coracoclavicular ligament, it leads you to transverse scapular ligament, under which you will find the suprascapular nerve. Now, there are a few indications when one needs to do suprascapular nerve decompression or ablation. And this is the arthroscopic video that demonstrates how to perform that, how to explore the suprascapular nerve. Now, my portal positions are here, looking from the lateral image and working through anterolateral and nevazial portal. And for this procedure, nevazial portal is slightly medial and slightly posterior in order to access the suprascapular notch. So, sorry. Yeah. So here, so the shaver is used to clear the soft tissue. So when going with the shaver, I go along the anterior border of the supraspinatus. And then once I have created some space, I go with the needle through the nevazial portal, and then go with the radio frequency, take some tissues down. And with the blunt trocar, I try to feel the conjoint, try to feel the coracoid ligament, that's coracoclavicular ligament, and then follow the coracoid ligament. That takes me down to the suprascapular ligament, transverse scapular ligament, and this trocar is used to retract the superior supraspinatus posteriorly, and through the same nevazial portal, the sponge or scissor is used to cut the transverse scapular ligament, and that exposes the suprascapular nerve. An important point to consider here is one should appreciate the suprascapular artery and try not to injure that. And that brings to the end of my talk. I think I've taken a long time. And this is my bibliography, and this bibliography shows all the anatomical videos and arthroscopic videos which I have taken from online sources. And thank you for your attention. I think I can take questions if you have any.
Yeah.
I'll stop share. Okay.
Yeah, wonderful, Dr. Amit. It was a very, very extensive and clear presentation. You tried to put together all the gross anatomy pictures and videos, and also the very clear arthroscopic videos. Thank you very much for making it a wonderful presentation. And Dr. Shreyas, you did a wonderful job putting in all the osseous anatomy and the radiographic part of it.
Thank you, sir.
Thank you very much. Okay, there is a very basic question with relation to the arthroscopic part of shoulder, understanding the shoulder. Dr. Amit,
yeah.
Do you recommend, what are the tips that you would like to suggest in order to have a clear picture inside the shoulder without too much of bleeding?
Yeah, with respect to bleeding, as a routine, we prefer adrenaline in the saline bag and the low hypertensive pressure as given by our anesthetist. These two are very good measures if you want to restrict the bleeding. Sometime one need to use tranexamic acid, that also got some effect. And other basic thing in arthroscopic surgery is as a beginner, you got two hands, so you have to learn triangulation. And an important feature with the triangulation is the jerking your when your left hand or the right hand, which is holding the scope, shakes. So that's That's one thing one needs to take care of. And the proper orientation, that's another important. If your orientation is not right, then you may not appreciate the structure properly or do the right job. So holding your scope steady inside the shoulder joint is very important.
Yeah, thank you very much. I think, as you said, arthroscopy just forms maybe 20 to 25% of the job. Getting the patient prepared, assessing the patient, positioning the patient, placing properly, having all the equipments with you, having a very good assistant with you. I think all these form the majority of it.
Yeah, you're right. I mean, all these are quite important, which you usually don't realize until you are on your own, and maybe with a new theater team.
Yeah, definitely.
One of the things about stopping bleeding is
yes, sir.
Initially, I unfortunately don't use adrenaline.
Okay.
But, you can first, when you put your scope, you can do a dry scope of the shoulder.
Yeah.
And shoulder is quite a big, nice joint. You can see many things unless you want to do something specific. The other important thing is you need to know your equipment. The pressure pump can be used judiciously because all the pumps have a flush mode, so you can flush the fluid, but you don't want to be flushing too much. So that takes a bit of practice as to when you should flush and when you shouldn't. And there are certain key areas in shoulder arthroscopy. If you touch them, they will bleed. So if you're doing a subacromial decompression, you want to keep your CA ligament till the last, because if you take it off first, you will get the CA artery and it will keep bleeding till you, and that is quite frustrating. And that comes with the time. And if you're doing a subacromial decompression, you need to know when to use your radio frequency to burn all the soft tissues, and don't take away too medial or too lateral. If you take your radio frequency too much there, then you may cause bleeding, and then it's very difficult to control them. So as you go along step by step, every time you see a bleeding spot, you burn it and then go to the next. So it requires a bit of method to burn your blood vessels and use your flush from your pump adequately, then you will find. And again, if you start with low pressure and gradually go up, you're better. But if you are starting at a very high pressure, and then you only have to go higher to stop the bleeding, and then the shoulder starts to swell. And a swollen shoulder is everybody's nightmare. If someone is big and you have a very swollen shoulder, not only your bleeding is a problem, your surgery also becomes a bit more complicated. So, I mean, using your fluid management system judiciously is very, very important to control the bleeding.
Thank you very much, sir. Very valid points. And Mr. Pandey, sir, can I have your suggestions with respect to avoid swelling, especially when you're doing an extra-articular procedure?
To avoid swelling?
In the sense, reduce as much as possible.
Well, experience has got no shortcuts. Your shoulders will swell if you're doing the first 10. You will put in a lot of fluid. So don't be too scared of it. And as I said to you before also, you're doing a cuff repair or something, and you think it's going out of hand, do a change to open. That is not but you need to know when to go. I mean, if you keep going. So initially you start arthroscopically, change to open. The next one you do more arthroscopically, less open. But to avoid swelling, there are a few important things. Firstly, most important is start low pressure-wise and go slowly higher. And it depends on how good you are in arthroscopics. If you are just starting out, you will take a longer time and the swelling will improve. The other thing is to get your portals right. If your portals are not right, and shoulder surgery is very, very important. Just a centimeter this way, that way, makes things so much more difficult. to visualize. And if you have a good assistant, that also helps a lot. So it's all about how much time you're taking to do a procedure. The longer you take it, the more swollen the shoulder gets. So you want to know precisely. I played it like a video in my head before I start the operation. And I'm thinking, well, at about half an hour, right now, I should be burying the anchor in the bone, and I've still not reached that stage. If I think I'm going to be significantly longer, then you need to change tack. So don't be too afraid of swelling. But again, if it's a big person or you've pushed in 5-6 liters of fluid inside, then you need to reconsider what you're doing. This is for the beginners. Once you become experienced, that's usually not a problem. I have a question
Yes.
To Shreyas.
Yes, sir.
About X-rays. You
Yes,
showed
sir.
a lot of views of these X-rays for the shoulder, which I have never used, and I've been practicing shoulder surgery for 25 years. What I would like to comment here is there is one important message which must go out to everybody. You always take 2 views of the shoulder. Always take 2 views of the shoulder. I still get a lot of messages on the WhatsApp with one X-ray AP of the shoulder and say, what do I do? No, no, no. If you wouldn't make a comment if it's a wrist fracture or a femur or a tibia, if somebody gives you only one view. So it is still practice that people do one shoulder view and then start thinking what to do. I mean, with the advent of CT scans and MRI scans, those other views are less important. But if you're doing an elective case, always have an AP. When I say AP, I always want a true AP. True AP is a good one. If you are doing an AP, might as well get a true AP, and always an axillary. Without these two, do not go anywhere else. The problem happens if there is a trauma situation. You can't do an axillary view. It is very, very painful. Do not accept a scapular view, that Y view. That is completely, in my opinion, completely useless. That doesn't tell you anything. Do not go for this subacromial space, that Rockwood view. That is also pretty useless. You might as well do an MRI scan. And all the other views which are there are pretty useless. So in my books, if it's an elective, you do a true AP and an axillary. If it's a trauma, you do a true AP and any other view which shows so we have what's called a strip view. In that, what we do is we lean back because the patient can't move the shoulder like that because of the broken bone. So you lean back and you take a picture like that, and then you get some sort of axillary. And there is a Nottingham view also. But I think those are the 2 views I will always take. In trauma, the axillary strip view, and in elective situation, an axillary view. There's no other X-ray required because in India, you all do CT scans if people have headaches and cough and cold. So why would you expose the patient to all sorts of radiation? That's just my comment, really.
Thank you, sir.
Yeah, that was going to be my next question to Dr. Shreyas. I was about to point towards what X-rays he would like to take in regular practice. Thank you very much for pointing it out, Dr. Pandey. Dr. Sriram, do you have anything to say with respect to the X-rays that you would like to take in a shoulder patient?
No, it was both. I would like to commend both of the guys. Amazing presentation for a non-shoulder surgeon to look into general anatomy and general arthroscopic views. Amazing intra-operative arthroscopic views for Amit, who pointed out. It was really good presentation, and I learned loads as well.
Thank you.
Thank you.
Okay. And as Dr. Pandey pointed out, as a beginner, it is very much important to know when you have to stop in order to proceed with a mini open surgical procedure, whether it is in the shoulder or possibly sometimes in the knee. for that, you also need to know the gross anatomy of the structures around the shoulder and also around the knee. For example, when you want to proceed from an arthroscopic rotator cuff repair, attempted arthroscopic repair, to a mini open rotator cuff repair, you need to know how long your incision can be. You need to know where your axillary nerve crosses the deltoid muscle. So that's a very important message that the beginners have to know. One thing is there has to be a point when they should not hesitate or shy away from opening the joint. And the next is knowing the gross anatomy of the region in order to avoid harming the patient. Okay, Dr. Srinivas?
Yeah.
Sashi, can I quickly, sorry.
Yes. Yes.
Please go.
I mean, having done my shoulder job with Mr. Pandey himself, what I found is that in our routine practice here, we mark our landmarks and incisions. I think as a beginner, when I learned with Mr. Pandey, that's what we did.
Yes.
Routinely, we position the patient, mark the landmarks, mark the position, mark the portals. As a beginner, I found that really useful.
Yeah, that's very necessary. And another thing is that when you mark the patient earlier and as the swelling increases, this portal changes. The portal where you marked earlier can change. And then that's what I follow is like, I would use my needle to again confirm that that portal which I have marked earlier is still the right portal. Otherwise, minor variation can be made at that point. But yeah, marking is utmost important. And I do always in my patients.
Totally agree with that. Yeah, I totally agree with that. And I wouldn't restrict marking the shoulder joint to a beginner. I still do that and make sure it sort of reconfirms my position, and swelling of the shoulder is a very important thing that can change the landmarks, whatever you mark also, but reconfirm it with your finger before making a needle prick or a incision. That's a very, very important thing that has to be done. And sometimes I even do it in the knee. Marking is a very important step that helps a lot with respect to this surgical procedure. Dr. Srinivas.
Very good presentations. Thank you very much, Shreyas and Amit.
Thank you, sir.
Thank you, sir.
I think they've covered it very well, actually, most of the things for arthroscopy wise. I think shoulder is traditionally considered to have 3 joints, isn't it? And 3 anatomical and 2 functional joints. So sternoclavicular and scapulothoracic, scapulothoracic and long head of biceps are functional, and ACJ, sternoclavicular and shoulder joint. We have covered shoulder joint in very much of a detail, and AC is also covered. Maybe sternoclavicular doesn't come under arthroscopy, but it's important to know.
Well, you'd be surprised, Srinivas. There are people who do a sternoclavicular joint arthroscopy.
Yeah.
There's a surgeon not very far from him, and I saw his name in Amit's bibliography. Graham, he does that. Well, but when he does that, he keeps a cardiothoracic surgeon handy. So I would advise you avoid it.
We thought about it, whether to cover a scapulothoracic and sternoclavicular, but I think it would have gone too far extensive.
It's not a basic arthroscopy.
Yeah.
You showed axillary nerve and all that. That basic arthroscopy should not get there. Actually, in 2 weeks' time, the shoulder think tank is doing a whole seminar on sternoclavicular joints. If anybody is interested, I can send you the link.
Yeah,
we'll do that. We'll do that, and we will also invite a cardiologist over to the in order to promote.
Not cardiologist, cardiothoracic.
Okay.
Just surgeon who can open it for you.
Yeah, we would like to attend that.
Yeah. Okay. Yeah. We thought clavicle and scapulothoracic were, the talk was getting too So we will have it another day. So we will also include the arthroscopy part, the sternoclavicular joint for the interest
No, I don't think we
and
should.
to know what is the update.
There are so many other important things around shoulders. Sternoclavicular joint arthroscopy
Yeah.
is not that important.
Yeah. So yeah. Thank you, Amit, for pointing out that the axillary nerve is very close to inferior pouch of the capsule. So that is a very important, needs to be considered when you do a repair of the inferior 6 o'clock position of bank lesion, the labral tear. So, Mr. Pandey, sir, can you give us some suggestions as to how you want to pick the labrum and avoid injury to the axillary nerve when repairing the inferior?
So I think the most important thing is you have to do an adequate release before you start repairing. So you make sure you release the labrum, which is stuck down inferior to the neck, and you release that. Start from the top, and before you go down, and then you reach to 5 o'clock. And when you reach the 5 o'clock, if you have released it adequately, you can actually see the areas where the axillary nerve could be. It's usually within a centimeter from the tip. So you release that, and when you put your first hole, it has to be at 5 o'clock. Don't try and put it at 5:30 or 6. Firstly, it's very difficult to put it there, and you'll be pushing and damaging the articular cartilage of the humerus. So stay at 4:30, 5 o'clock, and then put your drill hole there. And if you have released a lot of tissue, and don't use a burr to release your tissue, use something blunt or a slightly sharp to slowly lift all the tissues around. And then with a grabber, try and hold tissue which you can see. And for that, I use the superior portal to look right down. You can even look it from the anterior portal and look down. But grab hold of tissue before you put your needle through it. You can use a hook or something to see if the tissue is coming to the 4:30, 5 o'clock position. And this area, I have known one person who's a colleague of mine, not here in south of England, who did an anterior stabilization, and the patient woke up with an axillary nerve palsy. So that doesn't happen very often, but it's very important when you start with release. If you've released everything, you go right down, and then you can see all the tissue, and hold the tissue, pull it and see, and then try and grab it with your needle. Then you are unlikely to damage the axillary nerve. Sometimes if you pull too much, you don't want to tighten the whole thing too much also. If you take too much tissue and pull it up, you can kink the axillary nerve. That happens very rarely. So it's a good visualization, really. If you don't do it blindly, especially when you reach the 6 o'clock position, that area don't go down too deep. So it's all about portals and visualization, and knowing that there is an axillary nerve very close by. So most dangerous thing is when you're doing an arthroscopic release for contracture or frozen shoulder, because everything is shrunk. The axillary nerve may be closer to the inferior capsule than one would expect. And then if you start cutting there, you can damage the axillary nerve there. So as long as you're aware, most people damage axillary nerve when they're doing a total shoulder replacement, because you want to really get a good view of the glenoid and push everything back, and you can stretch the axillary nerve. So that's why when you are doing a total shoulder replacement to release the inferior bit,
pandemic. As we've seen at home and abroad, these are afoot to start opening up a
sorry, there's some. So when you release using a cautery, then if as soon as you
thank
start.
you very much for the points. It is.
So if you start getting close to the axillary nerve, it starts twitching, and then you are getting close to the axillary nerve. I don't know if there was some disturbance in there.
You're right, Mr. Pandey. I think the rate of axillary nerve palsy following the stabilization surgery is really, really low. But there have been a few reports, like the report which I quoted, that has shown 4 patients in 2,000 repairs. So it does happen once in a while, but yeah, one needs to be careful about that.
It's a devastating complication, because what kind of patient you do stabilization? You do stabilization,
Yeah.
someone who's very fit, is doing all sorts of sporting activities. If you damage their axillary nerve, you actually shot them in the head. It's a devastating complication. So a shoulder surgeon, before you start calling yourself shoulder surgeon, fall in love with axillary nerve. You should know everything about axillary nerve there is to know, and suprascapular nerve, because you do not want to damage. A lot of people do arthroscopic laphages and cause a lot of nerve damage, musculus cutaneous, and axillary and some brachial plexus. So you need to understand, okay, I'm going to do this procedure. This patient, if I didn't do this procedure, will this patient be able to do everything he wants to do? Yes, so you're just making a very little difference in his life. But if you give him a complication, you are absolutely destroying his life.
Mr. Pandey, I've got a question.
Yeah.
So from this point, the take-home message as a shoulder surgeon or arthroscopy surgeon to prevent nerve damage is, the take-home message would be to understand the anatomy, visualize. When you're looking at the visualization should be clear. The portal position should be absolutely spot on, so that the visualization is correct, so that you prevent the nerve damage. Is that correct? Am I understanding correctly?
Yeah, absolutely. The portal position and visualization is all about, that is all there is in arthroscopy, really. If you get a good view, you can do things. If you can't get a good view, you cannot, however good you are, you cannot perform what you want to perform.
Thank you.
Yeah, all the more in shoulder arthroscopy, it is very much important to know what should not be done, especially to prevent patient, and how you can save yourself in addition to patient. So it is important to know that certain things should not be done, or you need to be very careful. That is, one region is the inferior part of the glenoid. That is where the axillary nerve is there. And also, I will just like to add a point here, especially with respect to capsular release of the frozen shoulder. Most of the times it is still possible to just do a capsular release up to the 5 o'clock position and posteriorly, and just stretch the capsule and sort of tear the capsule, rather than actually doing a capsular release of your 6 o'clock position capsule. That will sort of prevent burning of the axillary nerve with the radio frequency. However, we need to be careful about this.
Sasi?
He's frozen.
So do a mattress stitch of the inferior capsule along with the labrum.
We lost you for about 10 seconds. Could you repeat, please?
Okay, I'm sorry. Okay, so I was talking about the capsular release. So in arthroscopic capsular release in a frozen shoulder, so it's just a corollary to what Mr. Pandey explained so far. So I'd just like to add that it is not advisable to do a radiofrequency release of the inferior capsule, because the axillary nerve is very close to the capsule. In addition to the contracture, the axillary nerve is expected to be closer. So it is sufficient to do a capsular release until 5 o'clock or 5 o'clock position, and posteriorly from 7 o'clock and up. And the rest of the capsule can still be stretched and sort of burst or torn. And this way we can prevent injury to the axillary nerve with the radio frequency. Do you agree with that, Mr. Pandey, sir?
Yeah, absolutely.
Yeah.
The key is to keep close to the glenoid.
Yeah, that is one way that that is advised. You can keep the radio frequency very close to the glenoid labrum. That way, you're not going to the inferior sulcus of the capsule. But we never know. In a frozen shoulder, the capsule could be contracted, and the tissues around the capsule could be contracted. So, yeah, that's one way to do. But it's possibly even better to not use the radio frequency in the inferior aspect.
Amit, what concentration of adrenaline do you use, and which patients you avoid using adrenaline?
So as a routine, it's 1 into 1,000, 1 ml of that. So that's put in 1 3-liter saline bag, normal saline. And it's a usual practice, and we confirm with the anesthetist if we are happy to put that. In case if he has an issue, then we don't do it. But overall, it's a routine practice in our setup.
Yeah, it's like 1 ampule of noradrenaline in 3 liters of saline, that comes to 0.3 in 1 liter. That was to, and subjectively, I have a feeling that it helps a lot.
Yeah, I think, but there are studies which have done arthroscopies with adrenaline, without adrenaline, and then studies have said that it doesn't make a huge difference. But again, is what you're comfortable with, whatever you are comfortable with. Your peace of mind is as important as patients. If you feel that is helping you, even if it's just a placebo effect, that's great.
So, Mr. Pandey, do you use anything at all for bleeding control apart from fluid pressure and judicious uses? Any kind of drug like tranexamic acid? I understand that you don't use noradrenaline, and you never come across.
We use tranexamic for arthroplasty.
Okay.
Arthroplasty we do before the start and for those afterwards. But for arthroscopic work, I don't, because that's the way I was trained. I was not, and I've not felt the need. I think if you see the bleeder and you go for it early, and as soon as it cuts, you burn it. And you have to alternate. If you want to burn the blood vessels, don't burn it with the yellow pedal, because that will cause more bleeding. You have to press the blue pedal so that it coagulates, because your radiofrequency can coagulate and burn. And most people just burn the whole thing because it looks nice. You know, you feel surgically you're doing something, you're making progress. But sometimes you want to stop bleeding, you have to use the blue pedal and be a bit patient. But yeah, with experience, you feel you use less and less other means, and you want to finish the operation within a particular time. But once in a while, yes, you will struggle with bleeding.
Okay, Mr. Pandey, can I ask you another question? You pointed out in stabilization surgery, you go up to 5 o'clock. Is that always the limit on your releases, that you never go beyond 5 o'clock?
You can go as down as you want. 5 o'clock, you put your anchor.
Okay.
You have to release further down, because you're going to shift the
pick them up,
and pick them up. But you don't want to start drilling below 5.
Below 5.
And when you release, when you're going below 5 after your superior portal, you have to be very, very careful. Do it with blunt dissection, slowly up, and then you can reach till 6, and then you bring it up. I mean, depends on how much tissue you need to bring it. If you've got a nice labrum, you don't have to go very far down getting the capsule. But if there is not much labrum, then you have to get the capsule, ligament, whatever you can get. But when you do that, be very, very careful what you bite, because the last thing you want to do is to
taking the axillary nerve.
Yeah. So when you get to that place, you start getting more careful. That's all.
Thank you, Mr. Pandey.
A question to Mr. Pandey, sir. Do you take mattress stitches in the inferior capsular labrum in any patients, like when the labral tear is extending all the way posteriorly?
I have, I use knotless anchors now, so I don't put knots there. The push lock are very, very nice. You just take bites in this thing. No, I don't. In that area, you got to be very, very careful. I have not felt the need to use a mattress suture, just simple stitches. 2 of them do as well. And I use 3 anchors mostly. Most of the times I use 3 anchors, and that gives me a pretty reasonable fix. But again, there is no hard and fast rules. The important thing is to have a good road hump on the interior in front of the glenoid. You want to have adequate capsular shift from inferior to superior. And if you've achieved that, And then the most important thing is the rehab. If you achieve that, that's very good. And the other important thing, before you start stabilization, you need to know, are you choosing the right patient? If you got the right patient, you will get a good result. If you got a wrong patient who has instability but has other things also, then you are unlikely to succeed. So it's very important. Sometimes you have to do a lathagy, and an arthroscopic procedure may not help. See, choosing the right patient is so crucial, especially in instability surgery.
And also the compliance, isn't it, Mr. Pandey? How is he going to?
That is very, very important. I mean, that's why I say you have to choose the right patient. You do a fantastic operation, and this guy is going to take everything out and barge into playing rugby within the first week. You can put whatever you want. You can put cement there, but it'll take it out.
Okay.
It's a partnership
That's a
between you and the patient.
Yeah, and it needs to be stressed, especially in the shoulder joint, that I mean, in addition to any other region, a clinical examination is very, very important. There can be a findings and actual clinical problem for the patient. So we are not in the clinical examination talk today. Am I audible?
We lost you for a couple of seconds, but yeah, you
Okay.
now.
Yeah, I'm sorry. Okay, I was just stressing that, especially in the shoulder joint, as in any other joint, it is more and more important in the shoulder joint that the clinical examination and the clinical diagnosis has a higher importance rather than the radiological or even the MRI finding. The selecting the patient will depend a lot on the actual clinical problem rather than even clear-cut pathology in the MRI scan. Yeah. Okay. And there is a question from the audience to Dr. Amit. Can you explain again the importance of the rotator interval?
Okay, yeah, rotator interval. First, we need to understand what makes the rotator interval. So you got structures in the rotator interval as coracohumeral ligament, superior glenohumeral ligament, and elongated biceps tendon. Each structure has its own importance, like coracohumeral ligament and superior glenohumeral ligament. In addition to giving stability to the shoulder joint, it also forms the part of the biceps pulley and stabilizes the biceps tendon in the groove. And the importance is understood more in cases in clinical scenario, like when you have a frozen shoulder, your rotator interval is quite contracted, and unless until you release the rotator interval, it doesn't move. So, and another situation where the rotator interval is quite lax in instability. So there you need to do capsulography. So that has again importance in movement and stability.
Yeah, that's very clear. Mr. Pandey, do you want to add anything to this?
No.
Yeah, okay.
Actually, there's a lot of controversy about rotator interval as to, is it just a space because there is a coracoid in the middle, one muscle is coming from top, one is thing, or it is there for a particular purpose. But whatever it is, it's very helpful to the surgeon, especially when people are now doing hemiarthroplasties or surface replacement arthroplasty without taking the subscap or down. So they're going it through the rotator interval to do many operations. So it's a useful thing to have. I think nature has tried to help the surgeons there. Now, some people say if there is a frozen shoulder, it gets contracted. Some people say if you have done a stabilization, closing the rotator interval helps to make it more stable. There is no evidence either way, but well, in orthopedics, there's not much evidence either way anywhere.
Okay, Dr. Sriram, do you have any comments on anything that we discussed today? Like, you want to add anything?
No, thank you.
Okay, Dr. Srinivas.
Yeah, no comments. Thanks.
You like a superstar, no comments.
I think that was a wonderful program. I think that was an awesome program. Thank you, Dr. Jalaria, and thank you, Dr. Amit. Thank you, Mr. Pandey, for coming over as a surprise guest. as a surprise guest for us. And thank you, Dr. Sriram.
No, no, I'm
And
not
as
against
usual,
that.
Thank you, Mr.
I learned a lot. Thank you.
Thank you, sir.
same on our side. And ourselves, Dr. Srinivas, and myself, Dr. Saseendar. Thank you very much. See you all again another day.
Thank you.
Thank
all.
you.
Thank you, sir. Thank you.
See you.